get a lot of referrals for overactive bladder, and most patients don't really understand what that is. So it's a symptom complex where the patient feels the need to urinate more frequently or urgently than they feel is normal, that's bothersome to them, and sometimes it's associated with urgency incontinence. Now, to make the diagnosis of overactive bladder, it's mainly based on history. The patient describes the symptoms that fit. Physical exam obviously rule out any other diseases going on, and then we do have to do a urine analysis or a UA to make sure that there's no blood or infection in the urine that could be explaining it. Basically, it's a diagnosis of exclusion. Once you exclude that there's no other cause of these symptoms, then we can assume that it's overactive bladder. And we usually don't have to do more invasive testing like a cystoscopy or urodynamics or other testing. We can usually make the diagnosis based on history exam and a urinalysis. So once you make the diagnosis, what's the first step? Well, the first step is to understand that a lot of this is related to dietary and lifestyle factors. So we do a thorough assessment of all the lifestyle factors that could be contributing. So first one is tobacco or any sort of nicotine products. These can cause overactive bladder symptoms because all of those chemicals end up getting filtered out of the blood and put into the urine and then can irritate the bladder. And basically, that's what you have to understand about this condition, is that the kidneys work as filters. They do a great job of taking any abnormal substances that aren't supposed to be in the blood and filtering them out and then putting them in the urine. So the urine is exposed to all sorts of byproducts of anything that you eat, drink, or smoke. So nicotine, tobacco is one of them. The other one is alcohol. Alcohol itself can be a bladder irritant, but it's also a diuretic, meaning it works like a water pill. It causes the kidneys to produce more urine than they normally would, so it's filtering more fluid out of the blood and putting it into the urine, and that's going to make you have to pee more frequently. And then the irritative properties of the alcohol and a lot of the drinks that we drink with alcohol can cause that increased frequency to be associated with urgency and sometimes even urge incontinence. Now, the biggest one is caffeine, most commonly coffee. And caffeine is similar to alcohol in that effect. It's a diuretic, makes your kidneys produce more urine, but it's also a bladder irritant. It makes the bladder feel the need to urinate, to squeeze down before it's time. So it has a lot of urgency associated with it. And caffeine has a half-life of about 5 hours, meaning that if you drink 2 cups of coffee at 10 a.m., that's the same thing as drinking 1 cup at 3 p.m. or half a cup at 8 p.m. So it takes a while for it to really get out of your system for you to get back to normal. Same thing is true with tea, has a lot of caffeine. A lot of sodas have caffeine, energy drinks. Sometimes these workout supplements that people take have caffeine. So that's a big one. Sometimes even decaffeinated products like decaf coffee, decaf tea have very little caffeine, but they have a lot of other chemicals in them that can irritate the bladder. Same thing with the sodas. Even if you're drinking a Sprite or something that doesn't have caffeine, it has sugar or artificial sweetener that can also cause you to need to urinate more frequently and urgently. The other ones that are less common are a lot of juice, like specifically orange juice. One, it has sugar, but two, it's a citrus. It can be acidic, and that acidity makes its way into the urine. So you have an acidic urine that can cause some of these overactive symptoms. Same thing with a lot of spicy foods. That tends to be acidic, and that can cause a lot of these symptoms too. Then the last factor is constipation. Obviously, it seems like it would be unrelated, but it's really not. If the rectum gets distended, that can just physically push on the bladder because there's limited space, but it's probably more complicated than just that. A lot of it has to do with the nerves. The sacral nerves from the bottom of the spinal cord that go to the bladder have the same nerve roots as those that go to the rectum. And we don't understand this fully, but there's definitely some crosstalk there that when the rectum gets to be distended, it can affect the signaling to and from the bladder and cause these overactive bladder symptoms. So the backbone and the first line treatment of overactive bladder has to be identification and modification of any of these lifestyle factors. And for the vast majority of patients, that's all they need. Now, if we're doing all of those things, or if we can't identify any sort of bladder irritants and the symptoms are still present, then we start talking about medications. So the first line medication are typically anticholinergics. The first one that people are often prescribed is called oxybutynin, or Ditropan is the brand name. This works well to relax the bladder muscle, but it tends to have a lot of side effects. Constipation, dry eyes, dry mouth, and in some elderly patients can cause some cognitive dysfunction. So a lot of people hate that medication and they end up stopping to take it. There are other medications in the anticholinergic family that don't have the cognitive potential side effects, like 𝐉𝐨𝐻𝐵, and we use these sometimes too. But then there are a whole separate family of medications that are not anticholinergic. They're called beta-3 agonists, like mirabegron or Myrbetriq is the brand name. And this is a great medication, works well to relax the bladder, and it doesn't have any of those side effects: constipation, dry eyes, dry mouth, cognitive dysfunction. It can, in a small percentage of patients, increase blood pressure, but as long as you're monitoring that, that's not really an issue for most people. The biggest issue with the mirabegron or Myrbetriq is that this is a newer family of medications, and it's more expensive, and oftentimes the insurance companies don't want to cover it unless the patient has tried one or multiple of the other types of less expensive medications. So if you can afford it, or if your insurance covers it, I would go straight to the mirabegron or Myrbetriq and not even mess around with the anticholinergics. But for some people, you need to start with the anticholinergics before the insurance will cover the other medications. Now, if the pills are not working, whether it's the anticholinergics or the beta-3 agonists, then the next line is Botox. And that's a Botox injection directly into the bladder muscle. And Botox is the medication that people typically use for wrinkles. It's basically a muscle relaxing medication, or paralytic essentially. And it can be injected into the bladder muscle through a camera, and that can be done with an awake patient if they can tolerate it, and most patients can. With a camera in the bladder, we basically inject the medication into the bladder muscle, and that's very effective to relax the muscle and have less of these overactive symptoms. There's several downsides to doing that. One is, just like the Botox that you would do for cosmetic purposes, it wears off. It varies, but about 6 months it tends to wear off. And some people come back and they get this injection every 6 months, and if they can tolerate doing it in the clinic, it's a quick and easy procedure, and if it gives them 6 months of relief, then it's worth it to continue doing it. The other factor is that it's a procedure, and all procedures have some risks, even if they're low. So there's a risk of infection, urinary tract infection, or UTI, anytime you put a camera into the bladder. If that does happen, it's typically just a simple bladder infection that just requires 5 days of antibiotics and it will go away. There's a risk of bleeding. We'll have to poke into the bladder muscle to inject the medication. We watch afterwards to make sure there's no bleeding, and if there is, we just sort of buzz the area that's bleeding and make it stop. But there's always a risk that some bleeding we missed, or it pops up later and can cause blood in the urine. Typically resolves on its own, but if it's serious, then patients end up in the emergency room and have to have that dealt with. Very uncommon, but it's possible. The other one that patients definitely need to be counseled about if they're going to get bladder Botox is the possibility for urinary retention, basically meaning that the injection or the medication worked too well at paralyzing the bladder muscle, and now the bladder is not contracting enough to get the urine out. This does happen in 2 to 3% of patients. It's self-limiting, meaning it goes away on its own. But in the meantime, we can't have you walking around with a full bladder for a week. So you have to have a catheter put in, or you have to do intermittent catheterization. So while most patients never have to have a catheter put in, with this procedure, they all have to be willing to have a catheter put in the event that they do develop urinary retention. So that's why we sort of save the Botox injections to be the last line of treatment. But overall, overactive bladder is a symptom complex that it often tends to be related to dietary and lifestyle factors. But if those aren't working, then there are medications. The medications aren't working, or if there's side effects, then there's Botox injections. And between those things, we can get 99% of patients feeling better.